Good morning everybody, and today what we're going to discuss is pituitary disorders. The objectives for this session is to describe the clinically important pituitary disorders, describe the clinical presentation and management of these disorders, describe the methods of diagnosis for these disorders, and for specific disorders the classification system with regards to them. Now essentially you'll remember that you have your hypothalamus, which is connected to your pituitary. Your central nervous system then sends signals to your hypothalamus, which then sends signals to your pituitary, which then results in either hormone release or alternatively activation of the hypothalamus, pituitary and adrenal axis. Your pituitary has an anterior pituitary and a posterior pituitary as well. And of course, it's quite close. Your hypothalamus and your pituitary are quite close to your optic chiasm as well. Now, your pituitary links the nervous system to the endocrine system. Your hypothalamus links the nervous system to the endocrine system via the pituitary gland, and it is located below the thalamus and above the brainstem. It is responsible for metabolic processes as well as the autonomic nervous system. It synthesizes and secretes neurohormones called hypothalamic releasing hormones. This stimulate and inhibit the secretion of pituitary hormones, and the hypothalamus is responsible for controlling hunger, thirst, fatigue, anger, body temperature, and also your sleep patterns or circadian rhythm. Your pituitary gland is the size of a pea. The anterior and posterior pituitary, which differ anatomically and functionally, they protrude at the bottom of the hypothalamus and they secrete hormones which are responsible for regulating homeostasis. Now, the anterior pituitary hormones, I want you to sit down and make a list of them and how they are activated. I'm going to give you a little while to do this. So what I want you to do is sit down, pause the video, and then write down all the hormones, right? How they are activated and what the effect will be. And when you're done, come back and then we'll continue with the posterior pituitary. The posterior pituitary is known as the neurohypophysis, right? It releases arginine, vasopressin or oxytocin. Oxytocin stimulates frequency and the force of uterine contractions as well as the release of milk as well. And of course, antidiuretic hormone or vasopressin is responsible for water conservation. It causes vasoconstriction and it's stimulated in volume depletion. Inhibition of ADH release can be done via alcohol, alpha blockers, and of course glucocorticosteroids. So the first condition we're going to discuss is acromegaly and giantism. Right? And just to give you a bit of a differentiation between acromegaly and giantism, right? In patients with giantism, what you generally have is excessive growth hormone release, which causes tall stature, right? And this generally happens before the person's before the epiphysis, right, of their bones actually stops growing. Conversely, in acromegaly, right, you tend to get extremity enlargement, right, and this tends to happen after the epiphyseal closures. So, both acromegaly and giantism result from growth hormone oversecretion. Their prevalence is anywhere between 2.8 to 13.7 cases per 100,000 people. And incidence rate is roughly between 0.2 and 1.1 cases per 100,000 people. Giantism is rarer than acromegaly and it occurs prior to epiphyseal closure in children, and it generally results in an extremely tall stature. Patients diagnosed with acromegaly have a 2 to 3-fold increase in mortality, usually related to cardiovascular, respiratory, or neoplastic disease. Right. Most patients are middle-aged at the time of diagnosis, right? There are no sex disproportionate effects. In other words, it doesn't affect women more than men or men more than women, right? Most cases cause excessive growth hormone secretion in acromegaly, right? and growth hormones secreting pituitary adenomas account for approximately 95% of all cases. Other rarer causes include ectopic growth hormone secretion, adenomas, growth hormone cell hyperplasia, and excessive growth hormone releasing hormone secretion, or a manifestation of multiple endocrine neoplasia syndrome type 1. Right, you can see here there is clear signs of acromegaly in terms of the size of the joints as well. Now, the clinical features develop over a period of time, right? And the physical appearance caused by growth hormone tends to be slow and very subtle, right? Most patients are only diagnosed with acromegaly after 7 to 10 years after the presumed onset of growth hormone secretion. Almost all patients with acromegaly will develop physical signs and symptoms of soft tissue overgrowth, right? Particularly around the extremities. You'll note that generally patients will experience the development of soft tissue overgrowth affecting multiple body systems, and signs and symptoms tend to come over a number of years. The patient may complain of symptoms related to local effects of growth hormone secreting tumors, such as headaches and visual disturbances. That's because of the visual disturbances are generally because it's of how close it actually is to the optic chiasm when these tumors develop. Other symptoms related to elevated growth hormone and insulin like growth factor 1 include excessive sweating, neuropathies, joint pain, and paresthesia. So, I mean, this could essentially be one of your differential diagnoses when you're considering what what may be causing the neuropathies in a patient other than diabetes. Another one could be acromegaly and giantism, and you'll specifically look at their extremities and look for soft tissue overgrowth as well, right? The patient may have coarsening of facial features, including increased hand volume, right? Increased ring size, increased shoe size, enlarged tongue, and various dermatological changes. The laboratory testing is that the growth hormone concentration will be greater than 45 picomoles per liter or greater than 1 microgram per liter following an oral glucose tolerance test, and insulin-like growth factor 1 secretion concentration will be elevated. Glucose tolerance may be present in up to 50% of patients. Now, I'll explain this test in a lot more detail coming up, specifically with regards to an oral glucose tolerance test, because an oral glucose tolerance test is not only used in the diagnosis of diabetes, but it's also used in the diagnosis of acromegaly and giantism. Right, common comorbid conditions include cardiovascular disease such as hypertension, coronary heart disease, cardiomyopathy, left ventricular hypertrophy are very common. And essentially what you could say is that these people are higher risk of developing cardiovascular disease. They will also develop osteoarthritis and joint damage in up to 90% of patients. Some will develop respiratory disorders, and approximately 60% of acromegaly patients end up with obstructive sleep apnea. Type 2 diabetes occurs in about 25% of acromegaly patients, and patients with acromegaly may have a higher risk of developing esophageal cancer, colon cancer, and of course stomach cancer as well. Now, the diagnosis is usually done via oral glucose tolerance test. Remember that random measures of plasma growth hormone levels are not dependable because growth hormone levels are pulsatilely released. Right? Remember that it's normal for you to have a little bit of growth hormone that's released in the morning so that you can wake up nicely. Right? Your oral glucose tolerance test can be used. Postprandial hyperglycemia is meant to actually inhibit the secretion of growth hormone for at least 1 to 2 hours. However, in patients with giantism or acromegaly, what you will have is an inability for growth hormone to be adequately suppressed. In other words, your growth hormone levels will actually be higher than will be higher than 1 microgram per liter or more than 45 picomoles per liter. More sensitive assays of growth hormone and insulin-like growth factor can sometimes be used, and in that scenario, the American Association of Clinical Endocrinologists suggests the cutoff of less than 0.4 micrograms per liter and less than 18 picomoles per liter to exclude acromegaly or giantism. In other words, if it's more than 0.4 and more than 18 picomoles per liter, that generally tells you that there is no suppression of the release of growth hormone. CT and MRIs are important because they are important diagnostic tests of the pituitary to confirm the presence of a pituitary adenoma. Okay, so the treatment of choice for patients with acromegaly is transsphenoidal surgical recession. In other words, removal of the growth hormone secreting adenoma by going transsphenoidally to actually remove the growth hormone secreting adenoma. Post-surgical cure rates have been reported in 50 to 90% of patients. Complications of transsphenoidal surgery include cerebrospinal fluid leak, meningitis, arachnoiditis, diabetes insipidus, and pituitary failure as well. Now, as we said before, ideally transsphenoidal surgery should be used, and that should induce remission. If it induces remission, you will then measure annually insulin-like growth factor 1 and random growth hormone levels, right? And you can consider the use of oral glucose tolerance test to measure whether or not secretion of growth hormone, secretion of growth hormone is actually suppressed. And if these biochemical signs and symptoms suggest reoccurrence, you'll then do an MRI to test whether or not this is the case. Radiation therapy may be considered at any point following an incomplete surgery. Right? If after transsphenoidal surgery there is incomplete disease, you then need to consider the use of medication. Right? Alternatively, if majority of the tumor is unresectable and there is and no chemical compression can be done, then after that the person becomes a poor surgical candidate and then also needs medication. You either need to use your dopamine agonists, or alternatively what you need to do is you need to use your somatostatin analogs. And essentially both partial clinical, right, and biochemical response to maximal doses, you'll have to then consider some kind of combination therapy. And if there is no clinical and biochemical response, you need to then consider an alternative monotherapy. If the medication is ineffective or intolerable, you then need to consider the person for radiation. Most common pharmacological treatments include dopamine agonists, somatostatin analogs, and growth hormone receptor antagonists. The ones we are going to concentrate on include dopamine agonists and somatostatin analogs. Dopamine agonists such as bromocriptine and carbogoline are generally effective in a small subset of the population. Somatostatin analogs are far more effective than dopamine agonists, and they reduce growth hormones and they reduce growth hormone concentration, and they normalize insulin-like growth factor 1. Now, generally, carbogoline is much more effective than bromocriptine, and in fact, meta-analyses have suggested to us that actually carbogoline is responsible for approximately 34% reductions in growth hormone secretion when used by itself, and up to 54% reduction in growth hormone secretion when combined with your somatostatin analogs like octreotide. Now we know that dopamine agonists would normally increase growth hormone production in a normal person. However, in acromegaly and giantism, you generally have the opposite effect, so they actually reduce growth hormone secretion. Bromocriptine needs to be initiated at a dose of 1.25 milligrams daily. That's half of the 2.5 milligram tablets at bedtime, and increased by 1.25 milligram increments every 3 to 4 days as needed, with a maximum dose of 86 milligrams per day. The problem with the doses that you're going to take of these particular agents is the adverse effects that are associated with them, and we'll get into that in a minute. A lot of patients experience dizziness when they use these medications, so it's worth taking that into account. And some of them have GIT upset as well from the use of dopamine agonists, and as a result of that, they sometimes have to take the medicine at night. Carbogoline is typically initiated at 0.5 milligrams twice a week and is increased to 0.5 milligrams every other day, so every second day, with a maximum dose of 7 milligrams per week. Dopamine agonists are generally a cost advantage over somatostatin because they are not complex proteins, and you can get many dopamine analogs nowadays as actual generics. Remember that dopamine analogs were primarily used to actually reduce not dopamine analogs. Dopamine agonists were are primarily used, to reduce milk postpartum in women who want to stop breastfeeding. The adverse effect of dopamine agonist therapy includes central nervous system symptoms like headaches, lightheadedness, dizziness, nervousness, and fatigue. Adverse effects decrease throughout the duration course, and I think the duration of the treatment course, and I think that this is worth pointing out to patients. A lot of patients tend to feel as though, the dopamine agonist, particularly when they take carbogoline, because they need to take it like the way that we've suggested before, we have to start off at 0.5 milligrams twice a week and then increase the dose to 0.5 milligrams every second day with a max dose of 7 milligrams per week. They tend to suffer a lot with lightheadedness, dizziness, and fatigue as well. And so you need to just remind them that, listen, these are the adverse effects you could experience, and remember that the longer that you take the medicine, the less likely you are to experience these adverse effects. They may, of course, thicken bronchial secretion and cause nasal congestion as well. And as I've suggested to you, they also cause adverse effects in terms of adverse effects in terms of their GIT tolerability, causing diarrhea, nausea, vomiting, etc. So sometimes people may consider taking them at night. The American College of Clinical Endocrinologists suggests a trial of dopamine agonists in acromegaly patients with mild signs and symptoms or moderate elevations in insulin-like growth factor 1. Now remember that dopamine agonists are ideally not meant to be used. What we should first try for is transsphenoidal surgery. Without transsphenoidal surgery, we then need to only try it in mild symptoms and modest elevations of insulin-like growth factor 1. Most of the time what we'll end up doing is combining dopamine agonists with somatostatin analogs together. Somatostatin analogs are considered a more attractive first-line treatment in the management of acromegaly. Octreotide, lanreotide, and pasireotide are long-acting somatostatin analogs that are potent in inhibiting growth hormone secretion. They are more potent than inhibiting growth hormone secretion than endogenous somatostatin. Octreotide is commercially available as both IV and subcutaneous injections, and it also improves cardiovascular manifestations of acromegaly. Usually octreotide is started at 100 micrograms, administered 3 times a day, titrated upwards to a maximum dose of 1500 micrograms per day, or a transition to a more long-acting version of octreotide as required. Octreotide doses greater than 600 micrograms daily generally do not have any additional benefit, and most patients are adequately managed between 100 to 200 milligrams 3 times a day. So even though the maximum dose is 1500 micrograms per day, most patients will only require somewhere between between 100 to 200 micrograms 3 times a day, so anywhere between 300 and 600 micrograms of total dose in a day. The development of gallstones is a potential long-term adverse effect for somatostatin analogs, and octreotide can increase the incidence of gallstones. Somatostatin analogs should result in decreased hepatic gluconeogenesis and increased insulin receptor sensitivity. Patients with diabetes should be more actively monitored, and glucose lowering medications require some kind of an adjustment. I think that it's worth pointing out as well that risk factors associated with worsening glucose tolerance include female sex and the elevated baseline insulin concentrations. Although somatostatin analogs have beneficial effects on glucose tolerance in most patients, right, glucose determination should be obtained frequently in the early stages of therapy, because in some stages, particularly in women, you may have elevated insulin concentrations and potentially worsening glucose tolerance as well. So, evaluating therapy. Appropriate monitoring of medical therapy for acromegaly incorporates assessing for control of biochemical targets and, of course, clinical symptoms. An age-normalized serum insulin growth factor 1 concentration must be actually checked, as well as a random growth hormone level. Those will be used to guide dosing and frequency of administration, and it is recommended to do this periodically. Glucose monitoring is very important for somatostatin analogs, because while it may be somatostatin analogs might improve glucose concentration in some patients, in certain patients, especially in women, you may have worsening of glucose tolerance in these patients, and so therefore you must take this into account. The next condition we're going to discuss is diabetes insipidus. It's a form of posterior hypopituitarism, right? And it results in a decreased production of ADH, and it's usually as a result of damage to the posterior pituitary gland. And the common causes include head trauma and neurosurgery, which lead to diabetes insipidus, but cases may be idiopathic. Now, the classification system for diabetes insipidus are, you have your primary central diabetes insipidus, right? And of course, there is no identifiable lesion on the MRI of either the hypothalamus and the pituitary, and there's some suggestion that this may be an autoimmune disease. Secondary central diabetes insipidus is the one we've discussed, where there is damage to either the hypothalamus or the pituitary stalk by a tumor, anoxic encephalopathy, surgical, and infection or trauma. Vasopressin-induced diabetes insipidus, right? This usually occurs in the last trimester of pregnancy, and circulating enzymes tend to destroy natural vasopressin, but synthetic desmopressin is unaffected. And of course, the other one which we'll talk about is nephrogenic diabetes insipidus, and this is caused by a defect in the kidney tubules which interfere with water reabsorption. Patients may have normal secreting levels of vasopressin or ADH, but have polyuria which is unresponsive. Most patients will have polyuria, right? And they'll also have polyuria with, of course, extremely dilute urine. So the urine will have a very low specific gravity. And it's characterized by the passage of a large amount of dilute urine. Patients produce more than 2.5 liters of urine per day. Patients will obviously experience water cravings as a result of this. And patients will also present with hypernatremia and dehydration without free water access. And it is aggravated by high doses of glucocorticosteroids. Patients will also experience nocturia, and as I said before, patients will produce a large amount, so they'll have polyuria with a very low specific gravity. Polyuria and hypernatremia must be interpreted with clinical judgment when you are diagnosing this condition. There is no one single test. You should do a 24-hour urine sample collection because this will give you an indication of the amount of urine in 24 hours as well as giving you an indication of the concentration of the urine, right? Remember that a 24-hour sample will consist to some degree of a sample that comes from fasting, so it will also tell you a little bit about the concentration as well. If less than 2 liters is produced in 24 hours with no hypernatremia, this excludes the diagnosis of diabetes insipidus. You also need to measure serum urea, glucose, calcium, potassium, sodium, and uric acid secretion. And hyperuricemia may be present in many patients with diabetes insipidus, and you may need to consider what we call a vasopressin challenge test. Now, what does a vasopressin challenge test consist of? Desmopressin is actually given at an initial dose of 5 to 10 milligrams intranasally or 1 to 2 milligrams subcutaneously or IV. Urine is then measured 12 hours before desmopressin is given and then 12 hours after desmopressin is given. And patients with central diabetes insipidus will notice a reduction in thirst and polyuria, as well as you will find a reduction in serum sodium levels as well. Diabetes insipidus is managed firstly with rehydration, right? And this can be done with either water or hypotonic fluids. Post-operatively, they may require, so this is post-operatively where they've actually had surgery on their pituitary. So, for example, one of the causes is transsphenoidal resection of a pituitary adenoma. And if the transsphenoidal resection of the pituitary adenoma results in diabetes insipidus, right, you then need to use desmopressin nasal spray 10 to 20 micrograms every 12 to 24 hours, or desmopressin, right, given 0.1 milligrams every 8 hourly, adjust to the maximum dose of 1.2 milligrams in divided doses, or alternatively you can give 1 milligram of desmopressin subcutaneously every 12 to 24 hours. Desmopressin may cause hyponatremia and emotional changes, so one must monitor the patient for the hyponatremia, right, as well as the potential emotional changes associated with it, such as depression and suicidal ideation. Desmopressin preparations are highly sensitive to heat, and therefore they must be kept with cold chain storage in mind as much as possible. I think other things to bear in mind is that oral desmopressin is useful in patients with sinusitis in comparison to the nasal preparation. Desmopressin does cause gastrointestinal system symptoms, and mild increases in hepatic enzymes can occur with the oral desmopressin preparation. Desmopressin can also be given intravenously, intramuscularly, or subcutaneously at 1 to 4 micrograms every 12 to 24 hours, or as needed to treat thirst and hypernatremia. Desmopressin, as we've suggested, can cause hyponatremia and emotional changes, and as a result of that, one must make sure that one is evaluating the patient. Next, what we're going to discuss is nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus is usually as a result of a cause from the kidney itself, right? And therefore you'll treat with 50 to 100 milligrams per day of hydrochlorothiazide, right? And these patients may respond to a combination of indomethacin and hydrochlorothiazide, or indomethacin and desmopressin, or indomethacin and amiloride. Indomethacin should be dosed at 50 milligrams every 8 hourly. Hyperprolactinemia is the third and final condition that we are going to discuss during this lecture. Right, now hyperprolactinemia is caused by non-gestational increases in prolactin hormone levels. Remember that there are a number of conditions or situations in which prolactin levels will increase. Some physiological causes include stress. Of course, breastfeeding can be another one. Pregnancy is another one. Certain medicines like antipsychotics, cimetidine, estrogen, methyl dopa, metoclopramide, opioids, nicotine, phenothiazine, protease inhibitors, progestrogens, reserpine, risperidone as well. Risperidone can also cause this problem. Selective serotonin reuptake inhibitors, testosterone, etc. And then other pathological causes that can lead to hyperprolactinemia include acromegaly, cirrhosis, hypothalamic disease, hypothyroidism, kidney disease, multiple sclerosis, optic neuritis, pituitary stalk secretion, prolactin secreting tumors as well. So there are a number of different causes, and they are very varied. Prolactin secreting tumors are by and far the most common cause in women when compared to men. Most of these tumors or adenomas are microadenomas. They're less than 1 centimeter in diameter. Some may be more than 1 centimeter in diameter and are classified as macroadenomas. Microadenomas do not grow in pregnancy or when a patient takes the combined oral contraceptive. Some patients may have giant prolactinomas, which are more than 3 centimeters in diameter. Now, giant prolactinomas can spread into the cavernous sinuses and the suprasellar areas, and of course, this will erode the floor of the cellar and then invade the sinuses as well. Hypogonadism and infertility is a clinical sign that you will find in men. Erectile dysfunction and diminished libido is another one. Gynecomastia and rarely galactorrhea occurs. Oligmenorrhea and amenorrhea may occur in women. Galactorrhea is equally very common in women, right? And this galactorrhea generally takes place in the absence of the patient nursing an infant. So that's a very important thing to remember, right? Pituitary prolactinomas may lead to growth hormone increases, and this then will, of course, lead to other problems, and I'm sure you are well aware of the problems that this will lead to, such as acromegaly and giantism, right? But of course, most likely you'll get acromegaly. Large tumors can also cause headaches, and it can cause visual symptoms and even pituitary insufficiency as well. And some women may secrete prolactin, which causes peripartum cardiomyopathy in these patients. Now, evaluate the causes of hyperprolactinemia are extremely important. You want to look out for serum HCG levels to decide whether or not the patient is pregnant, right? Or alternatively may have some kind of a tumor. Free T4 and TSH will tell us whether or not hypothyroidism is the cause of the hyperprolactinemia. BUN and creatinine are important. LFTs and serum calcium levels are also important as well, right? And LFTs are important because we need to exclude liver causes such as cirrhosis. BUN and creatinine are extremely important to exclude kidney diseases. Hypogonadism, you must measure total and free testosterone, total and free testosterone, luteinizing hormone, and follicle stimulating hormone levels. In amenorrhea, you must evaluate serum estradiol levels, luteinizing hormone, and follicle stimulating hormones. You may need to use an MRI, right? And you may need to use an MRI without contrast material as well. Patients with hyperprolactinemia not induced by drugs, hypothyroidism, or pregnancy must be examined using a pituitary MRI. Small prolactinomas may thus be demonstrated using the MRI by clear differentiation from normal variants is not always possible in these patients, right? In the event that a woman with macroprolactinomas, that means they are more than 1 centimeter in diameter, becomes pregnant and elects to take dopamine agonists during her pregnancy, an MRI is usually not performed since the normal pituitary grows during pregnancy. However, if visual field defects or other neurological symptoms develop in these women, and this is very important to note, right, a limited MRI must be done, focusing on the pituitary with gadolinium as the contrast. So you're going to use MRI with contrast in those scenarios. Hyperprolactinemia management includes dopamine agonists, surgical treatment, radiation therapy, and in some cases chemotherapy. Right, dopamine agonists are the management of choice in these patients with giant prolactinomas and those with hyperprolactinemia desiring restoration of normal sexual function. We primarily use carbogoline as the treatment of choice. Remember, carbogoline will reduce prolactin production, right? And we dose carbogoline at approximately 0.25 milligrams once a week for 7 days, and then we move up to 0.25 milligrams twice a week for 7 days, and then up to 0.5 milligrams twice weekly. Right? Your final dosage is dependent on the prolactin levels, with a maximum dose of 1.5 milligrams twice weekly. Now, it's very important for you to know the dosing regimen that is different from hyperprolactinemia versus acromegaly and giantism. Dopamine agonists should be prescribed at bedtime. This will reduce the GIT adverse effects, and it will also minimize adverse effects like dizziness, orthostatic hypotension that some patients experience, as well as the nausea. This is something we've said before, but I'm repeating again so that you guys are aware of. And also, adverse effects will improve with dosage reduction or with chronic use. And of course, they can cause psychiatric adverse events as well. Long-term use does not cause cardiovascular valve problems, and 90% of patients will experience a drop in their serum prolactin levels, which will reduce fertility and can result in pregnancy. So this is something that you must make your patients aware of, right? That what happens is that you will have a restoration of fertility, not a reduction, excuse me. A restoration of fertility by taking the dopamine agonist, and the patient could potentially fall pregnant in this scenario. Transphenoidal surgery is generally required urgently for large tumors undergoing apoplexy, or those that severely compromise the visual field because they actually are pressing on the optic chiasm itself, right? May be used electively in patients who cannot tolerate dopamine agonists. The mortality rate from surgery is less than 0.5%, but complications do occur, and we've discussed the complications associated with transphenoidal surgery, such as meningitis, CSF leakages, diabetes insipidus, arachnoiditis, etc. Post-operative hyponatremia may occur, right? And so you must monitor serum sodium levels for 2 weeks post-operatively. Microadenomas will result in normal serum prolactin levels in approximately 80% of cases, with a 13% recurrence within 10 years if they are removed using transphenoidal surgery. Radiation therapy is reserved for patients with macroadenomas, that is more than 1 centimeter in diameter, that grow despite having dopamine agonist therapy. Right? Surgical gamma knife or cyber knife treatment is preferable in patients with certain is preferable for patients whose optic chiasm is completely clear of the tumor. Conventional radiation therapy occurs within conventional radiation therapy what you'll tend to have is a treatment over a 5-week period, and this carries a high risk of eventual hypopituitarism, right? and that will then potentially cause diabetes insipidus as well. Other adverse effects include memory impairment, long-term risk of a second tumor, and small vessel ischemic stroke. So post-radiation, what is suggested is using 150 milligrams per day of a low-dose aspirin to prevent an ischemic stroke from taking place. When it comes to chemotherapy, patients with aggressive pituitary adenomas or carcinomas, and those patients must not be surgical candidates and they do not respond to dopamine therapy. We then consider temozolomide 150 to 200 milligrams per square meter given orally for 5 days for a 28-day cycle, of which 3 cycles are generally required for treatment efficacy, and treatment efficacy is determined by prolactin measurements and MRI measurements. Minority of patients will not respond to temozolomide, so the majority of ones who have aggressive pituitary microadenomas or who have carcinomas and are not surgical candidates and do not respond to dopamine agonists will respond to temozolomide therapy at 150 to 200 milligrams per square meter for 5 days based on a 28-day cycle, which requires at least 3 cycles for efficacy. And that's it, everybody. We have essentially reached the end of this particular presentation. Thank you very much for your time.